So thank you all for joining my presentation today. It's a very unique project Northern Health has implemented in 2021 to increase access to specialized mental health services for children and youth in Northern BC. So my name is Megan, and I'm the regional lead for child and youth mental health with Northern Health. Prior to this more strategic role, I did have the privilege of being a part of this regional support team in its pilot phase. So this project is really near and dear to my heart, and I'm really excited to share it with you. I also want to acknowledge that there were so many people from both BC Children's Hospital and Northern Health who have championed this work, both administratively and on the front line. So while I'm representing the work today, it is not solely mine. Um, Lots of people have poured into this. And I would like to acknowledge that I live and work on the traditional and unceded territory of the Lheidli. So that's colonially known as Prince George. Um, I would also like to acknowledge that our work is regional, and so many of my colleagues work on different traditional lands. And I'm very grateful to work in partnership and provide care in northern BC. I have a few kind of learning objectives today. So hopefully at the end of this, everyone can understand a little bit better the state of child and youth mental health within rural northern BC. Then I'd like to introduce the innovative regional support team project and our collaboration with the Compass program that had a goal of improving access to quality inpatient mental health care delivered close to home. And then to wrap up, just discussing some of our lessons learned and recommendations on using a model similar to this. So I'm going to use CYMH as an acronym throughout. So that's Child and Youth Mental Health. But this is a little bit of an overview of the state of mental health needs in Northern BC, specifically looking at what we were seeing prior to the implementation of the regional support team. So Northern Health serves a vast region. We have 32 municipalities and 55 First Nation communities spread out in our health authority. And we have a fairly young population compared to our provincial average. So 25% of Northern Health's population is under the age of 19. So we have lots of kids spread out among a lot of land. So for all of those communities that we serve, we only have one hospital that provides specialized mental health inpatient care, and that has 6 beds for our adolescent psychiatric assessment unit, or APAU, and that's located in Prince George. Um, in 2021, when we piloted the regional support team and Compass project, we had 619 pediatric mental health patients admitted to one of our sites. At that time, the average length of stay in the admitting hospital was 10 days. And then, if you were not discharged at 10 days, but if you were transferred to the adolescent psychiatric unit, you would be staying an additional 12 days on average for that specialized assessment. Um, so at that time, we were seeing kids staying 20 to 30 days in hospital for a mental health admission. Um, just for a little bit more clarity, I made a bit of a patient journey map prior to the support team to kind of understand what it would look like if you were a young person presenting at a rural or remote site in Northern Health. So in this picture, I have Alex. He's 16 years old and he presents to the Fort Nelson Emergency Department with suicidal ideation and a Tylenol overdose. So Alex would wait in that Fort Nelson Emergency Department to be seen by a physician. The physician would be able to provide medical clearance of the Tylenol overdose. Um, but due to discomfort dealing with suicide ideation and risk, Alex would be admitted to the inpatient unit there. We'll say the inpatient unit maybe has 6 beds as well, and that would be a mix of like elderly patients, maternity patients, pediatrics, kind of everyone would be in that space with Alex. So on the inpatient unit, there's no specialized mental health clinicians. The psych on call in the region would be specific for adult medicine, so would probably decline providing a consultation on this young person as they don't feel comfortable. And during Alex's 10-day stay in that unit, there would be no daily schedule, therapeutic interventions, or specialized assessments available to him. So after 10 days, he would finally be transferred via the patient transfer network to Prince George. For reference, Fort Nelson's about 9 hours away from us. So he would be taking an air ambulance without a parent or guardian to be transferred to our unit in Prince George. And then Alex would be admitted to APAU for an additional 12 days of observation, assessment, and initial treatment planning. Um, on his discharge, he would be provided with a safety plan from the team at APAU. His mom or caregiver would have to drive 9 hours from Fort Nelson to pick him up at discharge, and then they would make a 9 hour drive back home together following his discharge. Alex and his mom must reach out on their own to the local CYMH team to book an intake appointment. It is very likely that there is a 6 month plus wait to initiate community services. And to complicate things a little bit more, Alex does not have a GP, so he will need to go to a walk-in clinic to get a refill of his prescription for maybe he was started on an SSRI. So then a common theme that we were seeing would be that someone like Alex would represent to our emergency room within 30 days of his discharge. It would not be uncommon for us to find that Alex had stopped taking any of his medications that were started at his last admission. And it wouldn't be surprising to find out that either his family never made it to contact CYMH or that services had not yet been initiated. So we asked our physicians or our providers about how they felt about working with children and youth with mental health or substance use concerns. The providers included physicians, pediatricians, and general psychiatrists. And we first asked just how confident they felt in caring for this population using a sliding 0 to 5 scale. So as you can see here, care providers in our health authority really did not feel comfortable providing care for this population. So then we went on to ask about what their biggest challenges were, and we had 36 respondents identify 6 kind of main themes. Um, the number one challenge being related to accessing specialized services. So this includes access to a child and adolescent psychiatrist, um, being able to provide diagnostic clarity, other specialized assessments such as autism or psych eds, and concerns that there was no clear pathways for who to call or get support from. Next, our care providers indicated that there was a lack of knowledge and a general feeling of discomfort when providing care to this population. And examples included discomfort with the medications for pediatric populations, feeling as though there was not enough experience with this population, as most of our care providers typically practiced adult medicine. And then a feeling that child and youth mental health patients were higher complexity than other patients that they had seen in emergency departments. And then another really big theme that emerged was disposition planning. So, knowing what resources may be available in their community, how to access them, and then really what to do when there was a lack of community or care team supports. So, we were seeing lots of kids staying in hospital for extended periods of time. Because no one knew what to do, and nobody felt good about discharging to what was available. But then this just leads to young people staying in hospital, which we also do not believe is where young people belong. So, to address the increased emergency department presentations and worsening mental health and substance use challenges in children and youth since the COVID-19 pandemic, um, Northern Health created a virtual regional support team. So, this team was meant to ensure timely and equitable access to specialized mental health care and provide guidance and consultation to rural and remote um, sites to ensure that no matter where a young person lives, they receive standardized and quality care. Um, the team is to support comprehensive disposition planning, which ensures a seamless transition to follow up services. So this team is located in Prince George in an office space. And they provide supports over the phone and via video call throughout the region. Prince George is much more resourced than the other communities. So the team primarily focuses on rural and remote sites. However, we do also um, provide supports to more local youth, depending on need and um, kind of what is going on in the region. So the current staffing model has three positions, and clinical oversight comes from the APAU team lead. The Child and Youth Health Service Network provides direction on best practices and supports quality improvement and implementation of the model into practice. Um, this team is available 8 a.m. to 4 p.m. Monday to Friday. So right now it's kind of business hours. Um, and providers can call for support and advice. Um, the team will also take calls from the community mental health teams, school districts, and families. Um, so it's a kind of like a bit of an open line where anyone can call to get like education resources, understand care pathways, but then more clinical support provided to care providers. Um, the team also uses like a reach in approach to check in on mental health admissions. So we have a daily report that is generated and shows all pediatric patients admitted to the region. And then the regional support team can look at those charts and see what is going on for that young person, and they can reach into the local team to offer any additional supports that may be needed. A lot of the support is just consultation and talking through a case and understanding pathways and what's available. But the team can also provide virtual screening and assessment tools to help in the triage process of what needs to happen next. So the regional liaison role um, is the main coordinator with the Compass psychiatry assessments. Um, The role was designed to provide crisis counseling and support, as well as supporting the rural and remote emergency departments with those screening and assessment tools, as well as with discharge planning. The waitlist clinician role was developed to manage referrals to programs such as our youth treatment programs, transfers to higher level of care, such as the adolescent psychiatric unit, and may also support coordination of the eating disorders clinic or the early psychosis program. And this position also supports the emergency departments and provides consultation and other virtual supports. And then we also have a resource nurse who specializes in concurrent disorders and supports with substance use treatment and withdrawal management. And this position really provides education and resources and nursing support to our region. So the functions of this team were laid out as levels of service, and they are loosely matched to the Child Health BC tiers of service, which we use in BC to organize um, kind of what level of services are available at different sites for pediatric mental health. Um, so, really, the first priority or level one of this team is providing clinical expertise and crisis stabilization to the rural and remote sites who lack specialized care. So, the goal is to really increase equitable and accessible care, that all children should receive standardized care regardless of their postal code. So, this is like just providing like basic standardized care in sites that may not have capacity or staffing. Um, so that would be safety planning, risk assessments, really supporting the site with the least restraint guidelines, and ensuring that young people are safe when they're in hospital. Um, and then supporting transfers to higher level of care. Lots of our sites are rural and remote, and so um, specialized care does need to happen outside of that site when the case is a little bit more complex. Um, some of our other sites have more capacity to care for pediatric mental health patients. So the regional support team then would be coming in at like a level 2, 3 for providing care coordination and discharge planning. And really just stepping in to fill in the gaps when it comes to more complex cases, providing care coordination following the initial stabilization that the hospital was able to complete. And then at the highest level, the team functions to build capacity among the region and support providers to understand policy, procedure, and best practices. So this includes providing education, going on outreach trips, and supporting the implementation of clinical practice guidelines. So one of our biggest service gaps in Northern Health is that we do not have a child and adolescent psychiatrist providing acute care within Northern Health. So to address this, we built the regional support team, and then we partnered with the Compass program through BC Children's Hospital to provide virtual psychiatric assessments. So Compass is a program at BC Children's Hospital, which provides consultation to the province of BC. Um, their team is made up of psychiatrists, clinicians, and Indigenous care coordinators. And typically, a care provider would call the Compass line and receive direct consultation on a case for diagnostic clarity, medication support, or treatment planning. In our scenario or our partnership with them, they expanded their scope to provide Northern Health with direct assessments for our children and youth who were facing significant barriers and inequitable access to specialized mental health care. So the goal of our collaboration was really to provide more timely psychiatric assessment and evaluation for youth in emergency departments or youth who were admitted to an inpatient unit due to mental health or substance use concerns. So these virtual assessments take place over Zoom. Um, they intend to build capacity and to support the MRP. Um, and at the end of the assessment, recommendations for care, such as safety plans, medication, and diagnostic clarity, as well as readiness for discharge, are provided to the local team. So our regional support team manages access and triages cases that come in through the region. And we are typically able to offer 2 of these virtual assessments per week. Um, So the regional support team also facilitates the assessment. So they provide all of the collateral, get the team ready, and sit in with the psychiatrist from Compass during the assessment. Because the regional support team really understands the context of what services are available, what the community looks like, and can support the psychiatrist in that care team planning. So, our first priority for assessments are children and youth who are admitted to an emergency department or an inpatient care unit throughout our region. But we have been able to open up a small wait list for community-based assessments if we don't have an acute patient to fill the spot. Um, and those assessments can be referred by family physicians, nurse practitioners, pediatricians, and we have also let CYMH teams or community mental health agencies put forward referrals for a more timely assessment. And the assessments in community are meant to prevent hospital admissions. So since our project started in May 2021, we have seen 144 virtual psychiatry assessments in partnership with Compass. 80 of those assessments were inpatient, so youth admitted to a hospital, and they received that assessment in their local community hospital. And then 64 of those were community assessments referred by CYMH, pediatrician, or a community support team in order to avoid a hospital admission. Of the 80 inpatient assessments that we completed, only 18 of those kids were determined to need a higher level of care, so a transfer to the psychiatric unit in Prince George. Reasons for this may have been complexity of case, need for higher or more comprehensive care planning. And then a few of the young people that we saw were just really difficult to engage or provide diagnostic clarity over Zoom. And so it was determined that more observation was needed, and they were transferred to a physical unit to be provided care. Um, Northern Health is divided into 3 health service delivery areas or HSDAs. So we have the Northwest, the Northeast, and the Northern Interior. As you can see, assessments are like fairly well distributed between those service delivery areas. Um, but prior to this project, young people living in Prince George or the Northern Interior had way greater access and faster access to specialized psychiatric care just based on their geography. Um, so now there is much more equitable access to care throughout our entire region. And kids living in Prince Rupert have the same availability to to have a psychiatric assessment as someone who lives in Prince George. We also found that 55% of the young people that we were seeing through the Compass virtual assessments identified as First Nations, Métis, or Inuit. So in terms of cost avoidance, we have seen like pretty significant changes um, in um, in avoiding transfers. Um, so um, we sent 18 kids to APAU, so theoretically maybe avoided 62 transfers at about $8,000 per transfer. The community admission, so the 64 community kids we saw, none of them were admitted to hospital. And with our original average length of stay at 10 days, it's close to $1 million in length of stay savings. Um, and then the really significant, though, change that we saw was that we've reduced our length of stay by 45%. So in 2021, we were seeing kids staying for an average of 10 days. And now we are seeing kids staying for an average of 5.5 days um, in emergency departments, which is a savings of about $6,300 per admission. Um, it is difficult to really quantify exactly how much money this program has saved, as we didn't change the length of stay overnight. But if we consider that in our first year, um, we were seeing kids stay for 10 days, and if there was no changes, we could assume that they would still be staying for 10 days. So last year, alone, having 523 admitted cases with a new length of stay of 5.5 days, we could estimate that we reduced cost by over $3 million on length of stay. I think it's also really significant to point out that in our first year, we were admitting 619 kids. Last year, we only admitted 523. Um, while there may be other influencing factors as to why we are seeing less admitted patients, I think anecdotally, we could say that with capacity building, we have gotten better at identifying which young people need to be admitted, which young people need to be transferred, and who can be stabilized or provided some immediate crisis supports, but don't require a lengthy psychiatric admission for their presentation. So I have two case studies, examples of some of the work that Compass and the regional support team did together. Um, so our first case study for an acute presentation. We had a 16-year-old present to a rural emergency department over the weekend with an Advil overdose. This was their first presentation to an acute setting, but collateral showed us that earlier in the week they had presented to their family physician with concerns of declining mood and mental health. So that rural site was able to provide a nursing assessment, which included a mental status exam. And in that exam, the LP or the PLN, patient liaison nurse, identified some traits of possible bipolar disorder. So the young person gave a history of some decreased sleep, bizarre behavior, high risk behavior, agitation, and aggression. So they were admitted to hospital over the weekend. On Monday morning, the regional support team was alerted that this young person was in hospital. They were able to pull up the electronic medical chart, look at the nursing assessment, and identify some of these risks and concerns. And then the regional team could call the site and speak with the MRP and the nurse taking care of that young person to discuss concerns and next steps. It was determined due to the possible bipolar concerns that we wanted a more comprehensive assessment, and we were able to book a virtual compass assessment for the following morning. Um, so on Tuesday morning, the youth was able to see a child and adolescent psychiatrist via Zoom. So the comprehensive assessment provided the diagnosis of major depressive episode, general anxiety, PTSD, and cannabis use disorder. Um, so I just want to note that that's like a pretty comprehensive diagnosis that most young people are not going to get in an emergency department. So we were able to really spend time and assess this young person and comprehensively um, provide feedback on what was going on for them. So in that assessment, the young person did not quite meet criteria for bipolar, but did have two hypomanic episodes in the last year, and the mother was diagnosed with bipolar 1. So after discussion with the youth, the caregiver, the community team, and then considering the specific barriers in that community, the team decided to treat the major depression in the context of bipolar and started Seroquel XR. The youth was then discharged with their medication, a treatment plan, a referral to start DBT group in their community. And this was a 4-day admission. So they spent Saturday, Sunday, Monday, Tuesday in hospital and went home Tuesday evening following their assessment. For outcomes, within 30 days, there was no readmission of this young person, and they continued to stay connected with the community mental health team and were actively attending DBT groups. Um, Compass, though they only provide the one-time assessment, they remain available to the MRP for consultation and are able to provide advice on medication titration or if alternatives are needed. And the regional support team is now a part of that youth's care team and can step in if there was a readmission. So if we found that this young person readmitted to hospital, the regional support team would be able to pull up their assessments, look back at their chart, and direct the MRP and community care team back to the care plan, or they could escalate care based on the new presenting issues. So prior to this project, this youth would likely have had a 10-day admission in their community while waiting for a transfer. And then based on where they were, they would have been transferred via air to APAU and likely received the exact same diagnosis and outcome. Um, so in terms of like equitable care, this young person got to stay in their home community with their supports. Um, and receive the same outcome with more child-focused care and less risk of trauma. So I also have an example of a community case that we saw. This scenario is a little bit unusual, but I think it represents how flexible and adaptive our team has been in matching services to the needs of young people in our communities. So a mother called our regional support team looking for supports for her daughter and wondering about inpatient treatment options. The team was able to provide resources and education to the mom, um, but while talking, heard concerns of bipolar psychosis and worsening mental health symptoms, including isolation. The mom indicated that the youth was on a wait list for the local CYMH team and that the family physician was waiting for more specialized assessments as they were not sure how to move forward with providing care. So we gathered consent and contacted those care providers. So after getting some more collateral, the concerns of declining mental health in the community, including school refusal, significant weight loss, bizarre behavior, intense emotional dysregulation, we decided to put this young person through for a COMPASS assessment, and the referral was endorsed by CYMH and the family physician. In this case, though, instead of the family physician coming to us, we went to them to say that this service was available and if they would like to proceed. Um, so the family was able to attend the assessment virtually from their home, as this kiddo was really experiencing difficulty leaving the house, but she was agreeable to participate over Zoom. So typically, we refer community assessments to occur in a care provider office so that there's support in person in case of an emergency, if we needed to certify or admit someone, or if there was tech troubles. But through this process, we have learned that some people in their families cannot accommodate that, and we need to have flexibility where we can to meet people and families at their capacity. So this youth was given a diagnosis of OCD, substance-induced hypomanic episode, from a pre-workout supplement they were taking, and we determined a cannabinoid hyperemesis syndrome. So she was experiencing excessive vomiting throughout the day, which was originally thought to be linked to an eating disorder. It turned out that it seemed to be triggered by using marijuana in the morning. Um, so in consultation with this kiddo, she expressed a wish to not start medications. So we had the opportunity to talk at length about therapy options, and were able to immediately connect her with a private counselor, as her family did have access to extended benefits. And the physician was provided with comprehensive education around the diagnosis, and medication recommendations in case the child and the family decided that they wanted to go that route in the future. This case was probably seen over a year ago, and reviewing the chart, the youth has never presented to hospital for acute care following this assessment. So this is an example of how when we reach in, we can prevent kids from even coming to hospital. Um, Whereas before this program, this kiddo probably would have continued to deteriorate in hospital until their mental health became likely certifiable if they were refusing to leave the house. And that would be when we would have our first contact. In this case, we can see that we probably have better outcomes when we're able to intervene before kids are so unwell. So we've asked for a bit of feedback on this program. When asked providers about their experiences with virtual psychiatric assessments from Compass, 77% were satisfied or very satisfied. Um, when asked about capacity building and being able to understand the mental health presentation following an assessment, 77% of providers were satisfied or very satisfied. Um, and as this was initially a pilot project, we wanted to know about the sustainability and investing to make this program a staple as or a part of our continuum of care for child and youth mental health services. And 86% of providers found the service between Compass and the regional support team as fairly valuable or extremely valuable. Um, so PDSA cycles help deliver improvements in patient care through a structured experimental approach to learning and tests of change. Um, so from the very beginning of this project, we used this model through a weekly process meeting between Compass and Northern Health Administration and the regional support team. These weekly meetings continued for close to 2 years. And through this process, there were growing pains, and we did have to learn how to effectively work together without one agency leading the work. Um, I think this collaboration really requires curiosity, flexibility, and willingness to learn. Um, there is risk of ego getting in the way, and of power dynamics influencing how this care is provided. So really in this relationship together, we learned about how care is delivered differently in rural and remote communities, um, and how to be flexible and adaptive when our processes didn't match the needs or capacity of where we were working. Um, a quick example of that is when we first started, there was inclusion criteria that required a youth to be actively attached to a physician for follow-up. We quickly found that many of our rural and remote kids did not have this. So instead of declining services, we began looking at pathways to find these children physicians. Um, we built relationships with the communities and with First Nations Health Authority, and have been able to be advocates and leverage those community relationships and networks to connect young people for follow up in their community, or with a virtual physician. And we also found there was discomfort at times in navigating risk. There was ethical tensions, and accepting the reality that some of these young people face. At times was really hard. And there was many conversations as a team about what should happen versus what is happening, and what our role is in supporting young people in less than ideal conditions. So, in terms of lessons learned, I would say build in reporting and data indicators from the beginning, if you were to want to implement a model similar to this. Um, at the beginning, data collection was a little bit off the side of our desks, and not built into our reporting systems. So now, as we conduct larger reviews of this work, there is some challenge in looking at all of the indicators um, that we now know are important. Um, so it would be good to go in with a better sense of what we were looking to measure, and um, have more ease in pulling that information. Clear and consistent communication between organizations. So this was like really coming into this work with a spirit of working together. Um, it can be innate to want a leader, or for one of the organizations to want to take charge. Um, but it really wouldn't have worked if one of our agencies really said that we're leading this and making all of the decisions. This care had to really happen collaboratively. And our weekly meetings helped us to talk about challenges, review cases, and debrief what happened so that we were constantly um, doing those PDSA cycles and looking at how we can improve this service, and continue to improve access so that all young people were benefiting. Um, and I guess being flexible is a part of that. We started out with a plan and inclusion criteria, and then found barriers and different needs that we didn't originally anticipate. Um, so being able to adapt the project over time, but also adapting in the moment was very essential when working with young people. Um, the regional support team in Compass typically blocks their entire day for an assessment to be able to accommodate different needs, and ensure that we have comprehensive assessments and collaborative collateral and team planning. Um, while this is also a limitation and barrier due to the amount of time that we are spending with one child, I think that often the outcomes show that we took so much specialized time and we are reducing readmission rates. And kids are really receiving comprehensive care that fully meets the needs of the family. Um, then we found that implementation is ongoing as we face high staff vacancy and turnover. So, despite significant communication, the team providing reach-in support and outreach visits, we have still found that staff throughout our region are not aware that the program exists or what it offers. Um, so we experience high vacancy rates and high staff turnover at many sites. And many of those really rural and remote sites are staffed by agency nurses who may only be working a 1 month rotation. So we really are constantly in an implementation phase and needing to consistently reach out and educate sites um, just because there are so many new people all the time. And some of those small sites may only see a kiddo once a month. And so you just don't have that repetition or familiarity and may need to go through the process all over again each time. Um, and then looking at shifting culture. So, some of the big picture work within this team is shifting culture and narratives about the services and ultimately about children and youth. We find that 2 years into this project, many people still hold a narrative that kids have to wait months to receive services when really that's no longer true. So we need to continue to identify champions for this work and continue to advocate and model child-centered care. Um, we also probably need to address burnout and support care providers who are telling us there are discomfort in this work. Um, so yeah, there's still lots of work for us to be doing. Um, but we have made significant increases in services for our young people. And is really like excited and passionate to continue growing this work. So that's kind of all I have to say. I would love to hear from you. If at the end of this, any other questions or connections come up, you're welcome to email our general health, our general service network email at Child Youth Health, or you're welcome to reach out to me directly. Um, and I think if I'll stop sharing my screen, and if there were any questions, I'm happy to spend, I think maybe we have 10 minutes.
Hi, Megan. Thank you so much. Yes, you're right. We have about 10 minutes left. Thank you so much for the wonderful presentation. I think we might gather a few questions here in the chat. So we'll go on to some questions from the participants, and then we will exit the room in about 10 minutes or so following the break.
Sure.
Thank you again. That was wonderful. There's a lot of information packed in there. Lisa is asking in the chat about your funding. Have you been able to secure ongoing funding?
Yeah, that's a bit of a tricky question. I mean, we're continuing to run this program. The funding is a little bit spotty and pulled together from different targeted funds. Um, Initially when we started, I think that Compass was providing some of this service to us through their targeted funding. We have secured funding for the Compass psychiatry sessions, and then our regional support team positions are kind of attached to different programs right now to make it work. Um, but we actually are in the process of like reviewing the regional support team again and trying to add in some enhancements as we've learned through the process, and would like to um, really secure permanent funding for it.
Amazing, thank you. Please add your chat questions to the chat. We have a few more minutes left. Um, there is a message in the chat I'm going to read to you. I'm not sure if you can see it, from Megan. She says, thanks so much, Megan. Such a fantastic presentation and necessary work being done. The case examples were inspiring and reminds me of a recent report in Manitoba, which she posts in the chat. I don't think there's a question on that,
No,
but that is available for others to take a look at.
thank you. I would like to take a look at that later. As I said before, we are continuing to evaluate this program, and we know there is so much more room for us to grow, and looking at other models in BC and across Canada and even internationally, and how we can better serve kids who have specific to location.
Mhm. You mentioned some of the time that was spent traveling.
Mhm.
There must be a lot of costs associated to the families. Do you incorporate those costs in some of your outcomes in your reports?
No, and that's a really good point. A lot of families, so the PTN, or the Patient Transfer Network, does not repatriate kids in, I'm not sure if in at all in the province, but I know in our health authority, that's not an option. And typically, there's not room in an ambulance for a caregiver to join, and there's definitely not room in the air ambulance for a parent to join. So um, parents are sometimes traveling far distances, and if your young person is in hospital for a week, does that mean that you stay at home for a week waiting to hear that they're discharged, or do you come and stay in a hotel and wait around? So it's trauma and stress, leaving time from work, having to travel if you have other children and obligations. So it is significant barriers. Um, we have some access to like some of the bans will help families pay for additional travel. But there's also barriers in accessing those services in a timely manner.
Mm, thank you. I think Lisa's asking a question to everyone. Do others in Northern Ontario have similar programs or challenges? And Megan, what do you know about how other provinces might experience the same sort of challenges that you have faced?
Yeah, I would say I'm not very familiar with other provinces. I know within BC, um, our Interior Health Authority would probably have very similar challenges to us, and maybe some locations on the island.
Mhm.
Um, Based on geography. We also have in Northern Health have less resources than some of the other health authorities because we have a lower population. Um, but I think the data shows that our need that we see more mental health patients than some of the other health authorities do. Um, so like big system wise, how our resources are allocated sometimes doesn't quite like match the need. Of those health authorities. But I would assume throughout Canada, I mean, there's lots of rural and remote places, so there must be other people facing the same challenges. And there's a diverse population who experience different challenges and barriers.
Of course, yes. Thank you. We have a few minutes left. Please, if you have any other questions for Megan, add them into the chat before we leave. I was going to ask one more question, Megan. You
Yeah.
addressed a lot of it in the end, about some of the HHR challenges that you have. Of those, which are sort of more unique or more challenging to communities
Mm.
in northern BC, based on geography?
Yeah. Um, I think it really is in some of the smaller communities. It's not those aren't places that people are drawn to want to live and work. Um, so the access to any like specialized professions is really challenging. Like I said, we do not have any child and adolescent psychiatrists in our region. Um, we have some who are providing community and outpatient care, but we have no inpatient um, child and adolescent psychiatry. Um, we really struggle for any psychology. And then nursing and mental health clinicians. There is few of those. So, like I said, many of our sites are staffed by agency nurses who come throughout Canada. And there are different standards of care and different processes. So it's impossible to think that everybody knows what they're doing all the time. And so I think this regional team really helps set a standard of being able to reach in and make sure that everybody is on the same page.
Mhm. Wonderful. Thank you. Are there any other questions from the group? Please post them in the chat now. Again, Megan, thank you so much oh, there's Lisa popping on. She might have a question. Nope, she doesn't. I just wanted to say thank you. That was wonderful and very eye-opening to learn about the regional support systems and the programs that you're providing. So thank you so much.
Yeah.
You have some more kudos. Thank you. You're doing,
Thank you.
yeah,
Thank you so much. I really appreciate your time and being able to share this work and maybe build connections with some other partners. So thank you guys for your
absolutely.
time.
Thank you very much.
Thanks.